Welcome back to Healthwise. I'm your host, Reggie Tatum, and with us is Dr. Ben Sabagian, and we're talking about GERDs, or gastroesophageal reflux disease. Doc, you want to lead us into this? I know you have some slides and you have different things. Well, first, before we start that,
Sure.
What exactly is GERDs?
Well, gastroesophageal reflux disease, most people know it as basically the layman's term is heartburn. It presents itself as such. So most people, when they're talking about GERDs or gastroesophageal reflux disease, it's the reflux of gastric acid into the esophagus from the stomach. Generally, people feel heartburn, sometimes chest pain, sometimes shortness of breath, sometimes they'll get laryngitis, or from recurrent reflux, they'll get a chronic cough. Sometimes they'll have some recurrent pneumonia symptoms or develop pneumonias from it. But most of the time, the majority of patients have simply discomfort in the substernal region and in the chest. They also can sometimes have, many of them have problems with swallowing and difficulties with passing food from the mouth to the stomach, and have pain in the mid-chest from it. They can be associated, reflux can be associated with something called a hiatal hernia, which a lot of people have, but they don't really know what it is. And sometimes they're not necessarily, reflux can be independent of a hiatal hernia. People can have reflux without a hiatal hernia.
Okay. Yeah, because I know a lot of times on the ambulance, we meet people, we pick up people for chest pains and shortness of breath,
Right.
And then we find out after they're at the hospital that it wasn't actually a heart condition, but it was GERDs. Or,
right.
You know.
In those conditions, once heart's ruled out, then it's considered atypical chest pain, which that's why, as part of the workup for gastroesophageal reflux disease, I like to get a cardiac evaluation on people over the age of 45 or 50 to make sure that they don't have an occult cardiac issue that may be mimicking gastroesophageal reflux disease. In addition to that, there's several other tests that I typically get, including esophageal manometry and ultrasonography and a few other things that we'll go over later.
Well, you kind of answered the question. How does someone know they have GERDs? But if they suspect, I mean, they should just go to someone like you, or?
Typically, what most patients do is they'll go to their family practitioner and they'll tell them about that I have reflux, and the family practitioner will either send them to a surgeon or a gastroenterologist for endoscopy to evaluate that a little bit further. Many times those patients are put on medications such as proton pump inhibitors, which are basically medications, or H2 blockers. Those would be medications commonly known as Zantac or Tagamet, Prilosec, or Pepcid, that sort of thing. And patients will take that, they'll feel better, but a lot of times what happens is people just take the medications over and over again, but they never really treat the actual fundamental problem of reflux, which is an anatomic problem at the gastroesophageal junction. Okay. Let's say, for example, sure. If you don't mind, let me just, for the sake of the audience, let's demonstrate for them what I'm talking about. Here is the esophagus. The mouth is up here, and food comes in from the mouth into the esophagus and goes into the stomach, comme ça. And in the stomach, the food sits and it gets digested and crushed, and as it's getting pulverized by the stomach, this valve right here that we have demonstrated here flaps in this direction such that it closes off the esophagus and anatomically prevents the food from coming up the esophagus. This is normal. This is what normal is. This thing swings like so. In the case of someone who has reflux or heartburn, that particular valve is dysfunctional. And actually, let me draw that a little bit more clearly. If this is the esophagus, the valve has actually dissipated such that now you have this situation in hand, and the actual this esophagus is coming through an esophageal hiatus called the esophageal hiatus, hence the name hiatal hernia. And the esophagus is actually in the abdomen, and part of the esophagus is in the abdomen, and the rest of the stomach is in the abdomen. In this particular situation, the esophagus actually gets pulled up into the chest, and the hiatus widens out, and part of the stomach actually pulls into the thorax or the chest, and there's no more valve. This valve or this actual apparatus is gone, and so now you have actual reflux of food up and down the esophagus, which is the anatomic dysfunction. When you're taking proton pump inhibitors or Prilosec or Zantac, you decrease the amount of secretions and thus decrease the amount of reflux that occurs, but you don't fix the problem. So they actually feel a little better, but they're symptomatically not clear. Most patients who take proton pump inhibitors still have residual reflux or residual heartburn, even when laying down at night or with chronic reflux. So in this particular case, what you'd like to do is you'd like to actually fix this valve, which is involves multiple surgical options.
Okay, and you know, and I know you said with medications there's downsides and stuff, and some of those would be.
Well, with some of the medications you can have things like heart palpitations, osteoporosis, and quite frankly, the medications are expensive, especially if you're taking them chronically over a longer period of time. A lot of patients, especially in this day and age, it's tough to afford those medications.
Right, and the osteoporosis is just a calcium deficiency.
Osteoporosis basically is erosion of the bones secondary to either calcium deficiency or higher metabolism and erosion of the bones.
That's like taking all those antacids and stuff.
Correct,
like that. Okay.
Exactly.
Okay, Doc, well, when we come back, we'll look at some slides that you have, and I think you have some videos also. We're going to take a brief break for our sponsors.